So as you know, we don't usually do research seminars in the summer, but we make special allowances for special people, and we have a very special person today, namely Professor Srikant Sarangi. Okay, I cannot do justice to someone's biography like Professor Sarangi. So Professor Sarangi, I apologize in advance. But if I was to go through all your achievements, we'd be here all night. Professor Sarangi has been a professor in humanities and medicine for 3 decades, principally working in Denmark and the UK. During his career, he has written and edited 12 books and over 250 journal articles and book chapters. He is currently editor of 2 leading journals, Text and Talk and the Journal of Applied Linguistics and Professional Practice, a great journal. Over the past 20 years, he has had visiting academic attachment posts all around the world. It's easier for me to say that rather than go through the list of all the countries, just to say that he has basically worked on every continent apart from Antarctica, and he's currently visiting chair professor at the Department of English and Communication at Hong Kong Polytechnic University. So I will hand over, without further ado, hand the floor over to Professor Sarangi. I will, as he's asked me to, come on 10 minutes before the end to remind him. Okay, so over to you, Professor Sarangi.
Thank you, Jamie, and thank you all for making the concession to attend this talk, as I am told now that it is not usual to have something during the summer break. But without any further ado, I will go straight into the topic, what I want to talk about, and that is the articulation of risk and uncertainty, and looking at it from a communication discourse perspective. And what I want to do, given the time constraints, I will be mostly focusing on offering or proposing a conceptual framework with regard to risk and uncertainty research from a communication discourse perspective. So that is what I'll be spending most of my time with. And then hopefully there will be some time left to take a few examples from different healthcare settings, from the clinic and also from the public health sphere, only to illustrate the framework that I want to propose. Although I'll be focusing on risk and uncertainty, and I see this as a relational kind of pair that you cannot talk about one without the other. In fact, the notion of risks is born out of uncertainty. So risk, panic, crisis, disaster, uncertainty, and probability is what I'll be mostly focusing on today. But there are many other concepts that will be at least alluded to: the notion of normality, blame and responsibility, reassurance, safety, and equally importantly, knowledge and expertise. So although I'll be drawing attention to them, I will stay focused on risk and uncertainty. And I'm going to begin at the uncertainties end and try to argue in this first part that uncertainties mutate into probabilities and risk assessments. So how uncertainties become formulated or articulated in terms of probabilities and risk assessments, and that will take us to the notion of risk, and how these risk and uncertainties and probabilities are mediated through scientific expertise and direct and indirect evidence. And it is this expertise and evidence, the mediational means that would make ourselves relevant as language communication discourse researchers, because this mediation is going to happen through communication, through the lens of language and communication. So I'll be talking mainly from the healthcare setting, but of course not confined to the healthcare, because these are issues in all spheres of life, and particularly in the public sphere, in the economy, in environment, in the climate, and so on. But just to stay somehow grounded within the healthcare setting, let's begin with the notion of uncertainty, which is usually mapped onto a lay expert divide. So very classically in medical sociology in particular, we talk about the lay versus the expert. The lay are the ones who do not have the knowledge, and therefore they may be ignorant or most likely live with uncertainty, if not ignorance, because they lack technical expertise about their condition, about the remedies, about prognosis, and so on. In contrast to that lay perspective, the experts, the physician, the medic, they also live in a world of uncertainty, which is often characterized as calculated uncertainty, not a kind of loose uncertainty. So they have a way of calculating uncertainty, and that calculation of uncertainty is premised on the limits of medical clinical knowledge, but also their own individual expertise or skill base. In the context of healthcare experts, that uncertainty could include what is now being called variance of uncertain significance, VUS, particularly in the context of genomics and genetic sequencing. So what that means that a genetic sequence might show a change. The change can be linked, associated with certain disease risk, but that cannot be ascertained or with certainty cannot be claimed. In other words, if you do a scan, an MMR, an X-ray, whatever, you might find some traces of abnormality. Maybe there is a black something on the X-ray or the scan. So it is something that is significantly abnormal, but it remains uncertain because we do not have the knowledge to interpret what that exactly means. So that could be true of the COVID crisis. There are certain things that people noticed, but were not very clear to pin down what that exactly means. So the meaning making cannot be specific enough, even if we detect something of significance or salience, and what you might call metaphorically that there are flies in the ointment. We can notice this, but we can't interpret and digest it. So in the medical practice, there are two basic types of uncertainty that have been identified. One, which follows from Hughes, as I just mentioned, incomplete or imperfect mastery of available knowledge at the individual level. And then there are also limitations to medical, scientific, technical knowledge itself. And when we try to typologize these two types of uncertainty, we can already see that there might be a third source of uncertainty here, because we may not be always clear and might be ambivalent whether we don't know something or we are uncertain about some phenomena because of our own level of knowledge, that is lack of knowledge or expertise, or the lack of knowledge in the field, in the medical science itself. And when clinicians find themselves in these uncertain scenarios, either because of individual or field-based knowledge, they rely on opinion, subjectivity, judgment, intuition, because there is not enough biomedical clinical evidence or expertise. And that is what makes them to give warrants of certainty. So they might say, we don't have enough evidence, but we'll go by what I think and my hunch is. And that becomes the warrant for certainty. So uncertainty and certainty are managed through evidence and expertise. That's something to bear in mind. Then there are two other forms of uncertainty beyond clinical uncertainty. So many physicians would very quickly say and acknowledge that they're very uncertain about whether patients genuinely want to know something about their diagnosis or prognosis. So do they have a genuine desire to know what is to be known? Or would they not say how exactly they orient to what can be found out in terms of diagnosis and prognosis. And the fourth type of uncertainty would be many clinicians have not much knowledge about how different patients might react to bad news, whether the news is diagnostic or prognostic. So in other words, and I will illustrate this later, there are both risks and benefits to knowing and not knowing. And that is something that many clinicians and physicians are uncertain about. So uncertainty is not just our knowledge base, it's also about patients' desires and experiences and expectations. And in order to cope with such uncertainty, the professionals, at least in the healthcare setting, they use what is called a typification strategy. This is in the context of cancer. So what physicians would do in the cancer clinics, they would first allocate the patients into illness categories, types. And once people have been typified, or the patients have been typified into a particular condition, such as lung cancer or breast cancer or whatever, only then they will start to make or individuate the levels of certainty and uncertainty, which sometimes can include euphemism, that there is an element of vagueness and metaphors and so on, because things are still uncertain, but you still have to talk about it as if certain. And that brings me to one final concept, which comes in the context of childhood polio studies by Fred Davis, and what he refers to as feigned uncertainty, some kind of a pretentious uncertainty on the part of clinicians so that they can continue with treatment, prescribe more medication and interventions and so on, as if the outcomes were still uncertain, even when they know, particularly in the context of palliative care and end of life, that they know the outcome, but they still want to try everything. And this is to do with how medicine and medical profession is viewed in society as almost God, but it's also very difficult for the profession to accept medical futility, that more intervention is not going to make things any better, but worse. And that is very hard for many, many medical professionals to acknowledge and to communicate to their patients and families. So this is already suggesting that uncertainty is of different types, different layers across the experts and the lay people, and it is complex, it is nuanced. So now let me move from uncertainties to risk. And I begin with Ulrich Beck's very classic work on risk society. And what basically he argues is that in the sphere of economics, environment, health, public financing, the corporate sector, wherever we want to look in our society, there is typically not sufficient scientific capability or expertise to warrant certainty. So in other words, the problems faced in the context of any aspect of public life, we do not have enough scientific technical expertise to be certain. So therefore, we get into this way of calculating risk. So we try to make sense of uncertainty in terms of risk assessments, generating risk statements. And risk assessment then becomes a prerequisite, a precondition for taking actions, making decisions, because you need some kind of knowledge to make decisions about the future. So when there is no definitive knowledge, no certain knowledge, uncertainty can act as knowledge, but it has to be calculable uncertainty. We should be able to calculate probability, some kind of percentage. So those then become the way in which uncertainty is going to be formulated, articulated, in order to manage decision making. So we find ourselves in contemporary societies, both experts and expert systems, all the technologies, softwares, and so on, they generate risk rather than manage risks. And forget about solving risks. So what we have here is that the experts are not the ones who solve risks, but they also contribute to risks. They also generate risks of different kinds. So science determines risks, continuing with Beck, and people, the public, perceives risk. But we should be careful and make a distinction between how experts perceive risks based on knowledge and scientific rationality, as opposed to how lay people perceive risks based on ignorance or non-knowledge and their way of rationalizing what happens, or what we might call social rationality rather than technical rationality. So this division between experts and non-experts, or experts and lay, is quite fundamental to the public sphere, whether it is health, climate, environment, finance, whatever. And what is often regarded as a deficit model, it's premised on the fact that there are experts and non-experts, and that is a dichotomy that has to be maintained for the experts to have their authority, to have their status in the eyes of the public. So there is always a risk in the technological elite, the so-called experts, treating the public as if they are illiterate. They do not have enough health literacy, climate literacy, financial literacy, and so on, as if they're engineering students in the first semester. So this is a looking down, top-down deficit model in many public spheres if we want to maintain or subscribe to the dichotomy of expert versus lay knowledge. In later work, Beck juxtaposes between expert opinion with counter opinion. So experts are not any longer protected, a kind of a protected elite whose opinions cannot be challenged. So there is more and more counter opinions, particularly coming from the citizens and the public. So then we can talk about lay expertise, or what is often called citizen expertise, like movements in the public sphere. So these are citizens taking on the voice of expertise, probably drawn from experience, but of course they have access to the same knowledge as the experts with the revolution in ICT and so on. So we need to keep this, the rise of lay citizen expertise vis-a-vis the qualified, certified expertise, people who have got a qualification, a degree, or some kind of a mandate from organizations, higher education, and they claim to be experts. And this has been particularly the case with the notion of the expert patient. If you have a chronic condition, then you have far more expertise than your clinician in terms of how the condition can be managed. And this should be particularly relevant in the context of long COVID, for instance. So the long COVID patients will have more expertise based on their experience than the experts who do not have access to that knowledge. So now looking at uncertainty and risk as a relational pair, they are two sides of the coin, or even the same side of the coin. Now I'm moving to how uncertainty and risk are formulated or articulated in terms of probability, or what I referred to earlier as calculated uncertainty. So this is the anthropologist Mary Douglas. When she wrote about risk, she says that in current risk analysis, we notice that people turn uncertainties into probabilities, or what I called calculable uncertainty. So a great deal of risk analysis is concerned with trying to turn uncertainties into probabilities. So put a figure, put a percentage, put some kind of a quantification, and that makes it a probable statement, even though it is still uncertain in philosophical, analytical sense. And actually, the philosopher Ian Hacking said, any assessment of risk relies heavily on what he calls probabilistic reasoning. And there are two kinds of reasoning. One is an appraisal of the degrees of belief and evidence. So how certain and uncertain I am. And in linguistic terms, I can use epistemic modalities. I strongly feel, I have a hunch, I vaguely think, or I am almost certain. That kind of way of trying to express your degree of commitment to what you are going to say, the statement. The second kind of probabilistic reasoning is to try and reason with relation to norms and range. In other words, how the population distributes itself normally and abnormally. So what is a population norm? So what are the population risk figures, like, for instance, breast cancer? And then when something is more risky because it is something different or deviates from the population risk. So the second kind of probabilistic reasoning is the tendency of populations to produce very stable relative frequencies or ranges of events. And that then becomes the basis for calculating other kinds of certainties and uncertainties at the individual level. This is also corroborated by Stephen Tolmin, another philosopher, who says that the probability terms, they come to us and they function as a way of qualifying what assertions or speech acts, what actions, speech actions we make, such as promises, assessments, and so on. And they indicate the strength of the backing, how much we want to claim knowledge to the statement that we have just made, that assertion, evaluation, or whatever. So the quality of the evidence or argument that the speaker has at his or her disposal can then determine what kind of modality, epistemic modality, we might use, what kind of qualifier we are entitled to include in making those statements. So whether we should say this must be the case, or this may be the case, or this cannot be the case, whether it is certainly so and so, probably so and so, possibly so and so. And all these things can have very different meanings in the context of communication and discourse. So when we put probable reasoning, or what I'm now going to call probable knowledge, following from Reichenbach, another philosopher of science, he argues that when we make a statement like 50-50, 1 in 2, such a statement is premised on two principles. One is what he calls the principle of indifference, and the assumption of equality of probabilities. So 50-50 really means X might happen, and there is the same amount of chance that X might not happen. So the statement that a probability is 1/2 does not actually mean anything about the future. It simply expresses the fact that we lack the knowledge, or we have no more knowledge about X happening than X not happening. So we are 50-50, and we are basically back to the square one, and we are uncertain, but now the uncertainty is formulated scientifically as a statement of probability. And in any case, such probability statements, 50-50, 1 in 2, do not apply to individual cases. And this becomes a problem in the clinic setting, in cancer clinics, and so on, when the patient is told your risk is 1 in 30, 1 in 10, they say, I want to know whether the risk is high. Do I really have it or not? 1 in 10, a population risk figure, does not translate. So there is a problem of transferring meaning from a general population risk, to a particular individual case scenario. And very intriguingly, probability statements can never be contradicted by experience. So whatever experience people bring, counter experience, some kind of counter examples, it still doesn't quite refute the probability statement. And Michael Polanyi gives a very interesting example where he says, imagine the owner of a dog who tries to pride himself on training his dog. So in order to show that the dog always obeys his command and can never get it wrong, the command the owner issues is, here, will you come or not? So the dog invariably either comes or doesn't. So that means whatever the experience of the dog coming or not coming, the probability statements remain intact. So in other words, probability statements do not get contradicted by deviant experiences or some kind of deviations or counterexamples. So outliers do not necessarily refute the notion of probability. Then back to Reichenbach, who says, then why do we do this? If it is not going to help people understand their individual cases, if it is based on a principle of indifference, if we are not saying anything really informative or informed by making probability statements, 1 in 10 or 1 in 2, why do we do it? And what he argues is that we employ such probability statements because they help us to make decisions about the future. In order to make any decisions about the future, we need some kind of knowledge. And when that knowledge base, in terms of certainty, is not available, we are happy to make those decisions on the basis of what he calls probable knowledge. It is knowledge which is not definitive, but it is based on probability, and we can still use it in order to make those decisions in the future. So now I'm coming a little bit more close to home. How can we appreciate this notion of probability at the level of language and communication and discourse? And one of the ways, what we might call probability or likelihood. X, what is the likelihood of X happening? So we might give causal explanations, a causal formulation, a causal articulation, or we might give a probability articulation through the use of direct and indirect evidence. When it is a causal statement, it would be formulated as a if-then-always relation. So we can see at the level of language and discourse, there will be a formulation, articulation in terms of if-then-always. So that would be a causal statement relating to certainty. A probability statement would instead be articulated as if-then in a certain percentage. And that relationship is a marker of uncertainty. Now I finally want to make one further distinction, that we can talk about two kinds of probability, probability 1 and probability 2 at a communicative discursive level. And this goes back to what I was saying before about Ian Hacking, in particular, in terms of the degree of commitment and the spread or the notion of range or distribution. So probability 1 is how speakers show or demonstrate the degree of commitment to what they're trying to say. So they can claim insufficient knowledge, I don't know. They can disclaim, hedge, approximate and sealed, I'm not sure, sort of, nearly, and so on. They can attribute the claim to other sources and authorities. X is in a better position to comment. They can use different epistemic modalities, as we have already seen, may, might, possibly, could, probably, and also use of hypotheticals that could also work as a degree of commitment on the part of the speaker. The second kind of probability, probability 2, is about range and distribution. So we can think of the notion of range in terms of alphaness and betaness, following Neil, another philosopher. And there are three possible positions we can take in how we can articulate range and distribution in relation to uncertainty, and risk. So one position we can formulate as follows. It is necessary that anything which is alpha is beta, and that can be graphically presented as both alpha and beta belonging within the same circle, the same sphere. The second formulation would be, it is a matter of chance whether an alpha thing is the beta thing. So now you can see that the beta could be variously distributed on the margin, on the periphery of alpha. So there is a chance rather than a certainty with regard to the relational positioning of alpha and beta. The third, very clear-cut positioning would be, it is impossible that anything which is alpha should be beta. So then we have got two very clearly distanced circles. Alpha is not beta. And that's the kind of categorization that would happen in the clinic setting, in the public health setting, and so on. So to conclude this part of my talk, the conceptual framework in terms of risk and uncertainty from a communication discourse perspective, I think I have touched on 4 different things. And the communication is the kind of way of linking those 4 things. One is the level of knowledge, expertise, and expert systems. So this has a lot to do with how risk and uncertainty are formulated, articulated, but also managed and coped with. Then we talked about different types of uncertainties and probabilities. That is very important at a level of communication, how these are formulated, different levels of uncertainties and probability. For instance, does somebody attribute uncertainty to themselves in terms of their lack of knowledge, or to the field itself, that we don't know much about long COVID because there is not enough research as yet. Then these notions of uncertainty and probability are usually framed with regard to what evidence do we have. So what counts as direct evidence, such as scientific, biomedical, clinical evidence, or what counts as indirect evidence, which might be an association. We have seen some of these cases here, but not there, but we still don't have any direct evidence. Very similar to in the context of legal discourse, what is direct evidence, circumstantial evidence, indirect evidence, and so on. And these are then the ways in which we can establish levels of certainty, uncertainty, and probability. And when we talk about risk, then risks is mainly about risks of occurrence, whether certain phenomena is going to occur, such as a disease, for instance. But it's not just risk of occurrence, it's also risks and benefits of knowing that something will happen or might happen, or the risks and benefit of not knowing that if you have a genetic condition which might manifest when you are old, many of the conditions which are longitudinal and neurodegenerational, but they will only show up when you are older, such as Huntington's disease. But a test can be done today when you are 18. So what are the risks and benefits of knowing that you are going to have Huntington's when you are 65, more or less? And what are the risks and benefit of not knowing? And then following that, what are the risks and benefit of disclosing or not disclosing what can be known in terms of risk? So how the public health setting, if they know certain risks, what are the kind of things they want to tell now and what they don't want to disclose now, such as in the context of COVID and many other public health scares. Okay, so a communication discourse perspective on risk and uncertainty, I think I have worked on it for at least 20 years now, and I'm not going to demonstrate what a risk and communication, a risk communication, uncertainty communication perspective is, but basically I'm convinced that much of what I'm trying to talk about in this conceptual framework can be looked at in terms of communication and discourse. Okay, so here I want to mark kind of a closure to my main focus of the talk, to set out a framework, a conceptual framework, how we can look at, try to understand and approach the twin notions of risk and uncertainty through probability, but mediated through evidence and expertise. And by putting that statement as my conceptual thinking, I'm already beginning to suggest that this is very much our kind of area in terms of language, communication, and discourse, to look at the notions of risks and uncertainty, whether it is in the field of environment, health, finance, corporate management, and even family life, and so on. So it's a framework that is not confined to healthcare. But here I would like to pause for a minute or so. If there are anything people desperately want to ask in terms of clarification, then I'll see how much time we have got to give a few concrete examples from the clinic setting and the public health communication setting. So I'll just take a small pause in case there are burning questions.
So any questions from anyone? You can put them in the chat box if you're too scared to speak.
Okay, I mean, I'm taking it as I can progress. Is that right, Jamie?
Please do.
Okay, so let me give a couple of examples. One I'm taking from the oncology clinic. So this is to deal with lung cancer. And as I've said, I'm not going to do any detailed discourse analysis at this point. I don't think that is going to be helpful. But what I want to simply illustrate through these examples is how clinicians and patients make sense of risk and uncertainty through discourse, through their communicative strategies, if you like. So here is a clinic where somebody has been diagnosed with lung cancer, and they're talking about what are the possible treatment options. So the clinician says one possible and the very best treatment option is, of course, to go for an operation. That gives the best chance, I guess, of cure. Then the next best chance is by giving radiotherapy treatment, that is the X-ray treatment, and there is a chance that we can cure it, but not as promising, as certain as the operation. But note the use of the term chance and no mention of risk and no mention of uncertainty, but we can read through the notion of risk and uncertainty being articulated indirectly. So if we give the radiotherapy treatment, it's not a guarantee, but there is only a chance. Okay, so this is contrasted. I can't promise, but there is a chance, but then there is the downside, which is risk, but not mentioned linguistically, not mentioned explicitly. The downside of having the radiotherapy treatment is the effect on the lungs. Actually, the effect is euphemism, effect meaning that it will actually damage your lung, because the radiotherapy treatment is not magic treatment. It does have an effect on normal tissues, on all normal tissues. So basically, while trying to treat the abnormal, we will be affecting or damaging the normal. So that is the kind of risk. But again, still no mention of the word risk. The particular thing we have to worry about is the effect on the lungs. We can't treat this without damaging the lungs. So now we get the word damage to some extent. So even if we get rid of the cancer, that is, we cure it, you will still end up being more breathless. Will probably cause some scarring of your lungs, that part of your lung. That will mean you probably, and look at the word probably and how uncertainty is articulated, you probably lose about a quarter of that left lung. So now it is some kind of a quantitative formulation as well, a quarter of the lung, left lung. I mean, you know that that's the risk you take. This is the first mention of the word risk, but not risk as an absolute risk, as an objective risk, but the risk you take. Is more about risk taking rather than the phenomenon of risk associated with radiotherapy. Whether it is safe, and I think it's a reasonable risk to take. So the risk is now, the taking of risk is being qualified as a reasonable risk. I think it's worth taking the risk. Otherwise, things can get worse. So that is the risk if you don't take the risk. Still, I must keep saying there is no guarantee that I can cure you. There is quite a chance that I'll make the breathing worse. And here the word chance is clearly meant as risk. That there is a risk that you will now become breathless because of radiotherapy. But then there is a realistic chance that we can get rid of the cancer for you. So this is what I'm trying to suggest, how risk and uncertainty are articulated, not always explicitly. It's not something that one can capture through corpus linguistics or simply by looking at the use of words in explicit ways, but something that we can interpret within a framework of probability, uncertainty, and risk. And how the words such as chance, which is particularly salient in this particular example, actually is being used both positively and negatively. A chance of cure, but also a chance of doing something damaging. So what we saw is the term risk appears only 3 times in this extract, but mainly to do with risk taking. Worth taking, it's a reasonable risk to take, but not risk as an objective kind of absolute phenomenon. But that objective risk is alluded to in various ways, such as the downside, the effect, damaging, it will cause scarring, it will get worse, you should be worried, it will end up, you will lose 1/4 of your lung. All those are alluding to the notion of risk as an objective phenomenon, but not using the word risk. And intriguingly, as I have already pointed out, the term chance is used both positively, chance of cure, get rid of cancer, but also negatively, the risk of something adverse happening. And both chance and risk are qualified. It's quite a chance, realistic chance, the best chance, the next best chance, reasonable risk, worth taking the risk. So now we are confronted with the notion of objective risk, reasonable risk, risk-taking, and it is through that we have both positive and negative framing, escalation and de-escalation of risk in this particular context. But we need to talk about this in this probabilistic way, because you have to make a decision whether you want to go for operation, radiotherapy, or not do anything at all. So this is where future decision-making will be premised on how we articulate uncertainty and risk in terms of probabilities and so on. A second quick example I'm taking from genetic counseling, and this is about familial breast cancer, that is cancer that is inherited within the family rather than the general population breast cancer. So I will not go through again, this is a much longer extract, but I'll simply draw your attention to the bits that I have highlighted just to make this a similar argument about how doctors or clinicians try to formulate, articulate risk and uncertainty at the same time by escalating and de-escalating, but also making connections to risk in the normal risk in the population as opposed to individual risk in the family. So breast cancer is a common condition. Between 1 in 10 and 12 women develop it at some stage. That is the population risk. but it can also be a familial risk, that many people in the same family also get breast cancer, and that is the remit of genetics. So we can then identify a gene to see whether breast cancer in itself is within the family, but not by chance, but there is a particular gene which is responsible for this inheritance pattern. So whether it's a chance or whether we think there might be a gene involved in your risk of getting it. So then they take the history of the family, who got cancer, breast cancer when, at what age. So this has to be people getting it at a younger age, but also getting a cancer on both breasts, not one. So those would be the kind of calculations they have to make. Then we can do a calculation. So that is the calculable aspects of uncertainty and risk. The chances are that there might be a gene running in the family. So here again, you see the chances, meaning the risks are. And what we think your own risk of having breast cancer in your lifetime, and if it will be increased somewhat if we found a faulty gene within your family. So then your risk is higher. We have already done that calculation in relation to the general population. So this is very important, that your risk is higher, but that always implies that it has to be a comparison with the general population. What is the norm? And if your risk, as we calculate it, is 30%, then the client here says, is that high? High, is it? And the counselor says, yes, it is significantly high, but it has to be taken with a pinch of salt. 3 out of 10, you would have a chance of breast cancer, so that is 30%. But then again, 7 times out of 10, you won't develop breast cancer. So that is de-escalating the risk. So your chance is about 3 times as high as the general population, because the general population is 1 in 10, yours is 3 in 10. But if we could find an alteration, because your risk is sufficiently high enough already now, then we do a genetic test. And if we find that faulty gene and it shows there is an alteration in your gene, then your risk will actually be a lot higher than 30%. It will be more like 80%. And the client here says, so basically that's virtually definite then. Well, still there is still 20% chance that it isn't. So it is still an 80% chance and 20%. So what I was trying in my conceptual discussion is sometimes these probability statements do not translate into individual scenarios, because whether you are 1 in the 80 or 1 in the 20, nobody can establish through these population risk figures. If we showed that you didn't have an alteration in the gene, then your chance falls back to 30%. So you should be very happy and go along with having the test, because we can then bring you back to the 30%, and that can only be done through a genetic test. But if you decide not to go ahead with the test now, that's your decision, and then you have to talk to a breast surgeon, and we can make an appointment for you for doing that. So just to summarize some of the things, what we find here is what we have called how risk is relativized in a clinic setting. So there is a notion of abstract risk, but is often reformulated in terms of how it can be made sense with relation to the individual's risk factors or risk assessment. How risk can be localized and how risk in the population can be externalized, but it informs what we can make in terms of decisions about tests and surgery and so on. But then there is this issue of temporalization, the time and space. I don't think I'll have time to develop that today, but then the notion of time and space become very important in terms of decision making. You may not have developed the risk on both breasts now, but in 10 years' time, it might, given the family tree, the inheritance pattern. So then we can temporalize the risk in terms of time frame rather than just localized and individual risks. And equally important is what agency do you have? So things that you can do because it is breast cancer, you can remove a breast, and that is your power, that is within your power and in your decision and your agency. But if it is a neurological disorder like Huntington's, you have no agency. So the discussion of uncertainty, probability, and risk will not only have to be articulated differently, or even if articulated in the same way, the decision-making will be very different. So that would be what I meant by escalation and de-escalation of risk.
10 minutes. 10
Yeah.
minutes, Professor Sarangi. 10 minutes.
I think I will not go into the public health scenario, and I'll just simply conclude with the 2-3 slides now. So what I'm going to suggest is, in these examples, we can see that even when clients come to a cancer clinic, whether it is familial breast cancer or oncology, I think they pretty much expect that there will be all kinds of probabilities, calculated risks, and uncertainties that the doctors are going to formulate. So one question is, why do they come to receive such probability assessments? I think the reason why they do that is that way they can demonstrate or display that they are accountable individuals, and they want to do what can be done in order to either protect other family members or their relatives or friends or their family members and so on. And at least probability statements are often seen as reducing uncertainty and as a way of moving on to making decisions. On the part of the professionals, they tend to use probability 2 statements, particularly what we saw in the genetic counseling setting. That is the statements about population risk, range distribution, what is normal in the population. And they try to use those in order to somehow preface their probability 1 statements, that what kind of commitments they want to make to decision making. And there is an interplay between the probability 1 and 2 statements, which allows the professionals to leave the decision making non-directively and neutrally to the clients. So risk management then becomes a matter of communicating evidentiality in the way that I have shown with regard to probability statements and so on, risk statements, while also trying to escalate and de-escalate for psychological and socio-moral reasons. So what you find here is there are 3 axes of risk engagement. One is the biomedical axis, the clinical biomedical spread, the family axis in terms of what you might call the social, the extended family, the immediate family, the individual, and so on, and the temporal axis, which is the past, present, and future. And as I had indicated earlier, the risks are not about just the risk of occurrence, that is R1, but also the risks of knowing, as well as the risks of disclosure or non-disclosure. So when we get to mapping the notions of risk and uncertainty and the tensions that are inherent, from a communicative perspective, we can say that how the discussion progresses within a clinic setting will be along 2 axes. One is the present future uncertainties, the temporality. The other is the consequences of the decisions that you make. So when the uncertainties and the consequences are low, we can go for very, very invasive medical intervention. But when they're relatively mid or high, the consequences, we are not very sure, uncertainties remain, then we get much more into the psychological, and when they're really high, into the more socio-moral, ethical dimension. So I think I'll stop here. I probably had thought about how to illustrate that in the public health setting, but that has to wait.